We'll be talking about intercoronary imaging. We'll talk about plaque characterization, IVUS, and OCT. So we'll review some basic principles of IVUS and OCT. We'll compare the advantages and disadvantages of these imaging modalities. And we'll briefly discuss the clinical data on the use of these modalities. So these are some of the things that we're going to cover. Before I proceed, I want to thank Dr. Yang for giving me these slides. These are his slides. I borrowed a lot from his slides and also from Dr. Sandoval, who had previously done his presentation. So let's get into a little bit of the physics first. Wavelength and frequency. As you all know, wavelength is the distance between identical points in adjacent cycles of a waveform. So from peak to peak or trough to trough, that's the wavelength. And the frequency is the number of cycles of a waveform per second. When we look at the depth of the image, it relates to the penetration of sound and light wave. If this is the object of interest, you're seeing kind of in this schematic diagram, there's inadequate depth for imaging. If this is the object of interest, you have good depth and you'll be able to see this when the image is reconstructed. As a general rule, the larger the wavelength, the better the penetration. So as for any ultrasound system, even if you take ultrasound probes, if you've got a lower frequency, you can see deeper structures easily. For more superficial structures, you typically use a higher frequency probe. So same thing in the coronaries. When we talk about resolution, resolution refers to the ability to discriminate between 2 points. There's axial resolution, which is resolution parallel to the beam. And there's lateral resolution, which refers to resolution perpendicular to the beam. In this schematic diagram, again, you see that there's good resolution. So when you reconstruct the image, you can see the 2 dots as 2 dots. But when you have poor resolution, they tend to merge, and you cannot distinguish the two. One of the things that you have to bear in mind is that frequency, penetration, resolution are all interrelated. If you have a high frequency, you obviously have a shorter wavelength. You have shorter penetration, but you have very good resolution. If you have low frequency, you have a longer wavelength with more penetration, but with relatively poorer resolution. There's also contrast resolution, which refers to the ability to discriminate between variations in grayscale. It depends on the ability to detect changes in the amplitude of the reflected signals. If you've got a good dynamic range, you can see different shades of gray, but if you've got very low dynamic range, you're pretty much going to see just black and white. So how does this work in an IVUS catheter? Essentially the same way as it works with ultrasound elsewhere. There's an electrical current that's passed through a piezoelectric crystalline material, and that creates sound waves. And the sound is released and reflected back, and that data is then taken and reconstructed into an image. With respect to coronary IVUS catheters, there are 2 different types. These are the types of transducers that are available. One type is the mechanical transducer, which is a single transducer that is rotational. It rotates at 1800 RPMs per minute, 1800 RPMs, and it gives you a frequency of 40 to 60 megahertz. The other type is a phased array system, which is stationary. There are 64 transducer elements on this, and it will typically give you a lower frequency of 20 megahertz. The way these catheters work also affects the construction of these catheters. So if you look at rotational systems, because of the presence of the drive shaft, the monorail is typically very short. This becomes relevant because sometimes when you're trying to push these types of catheters around a tight angulation, they can prolapse because that monorail is relatively short, even though they're slightly lower profile compared with the stationary systems. In a stationary system, you've got a longer monorail, which gives you a little bit more pushability, but that sometimes is negated by the bulkier tip of the catheter. And I'm sure a lot of you have experienced with the use of both of those catheters have seen this. The devices that are currently available, Boston Scientific makes a rotational system. It's a high-density IVUS system, 40 megahertz or more. It requires a motor. It has nice spatial resolution because the frequency is higher. Philips currently has the stationary system, which is a lower frequency system with less spatial resolution. But one of the things that it also offers is chromaflow and virtual histology. Chromaflow is basically looking at radio frequency data from sound waves that are reflected back from moving red cells, and it converts it into kind of a relative velocity map. And it looks like this. It's a very useful feature, especially for certain types of interventions when you're trying to see if you're getting into a true lumen or not, where you really are in a coronary or even in a peripheral. It's a very useful tool to have. Virtual histology, again, this is based on the fact that different tissues have different degrees of signal attenuation, and you can take that and construct it into an image. And if you've got reasonable grayscale that allows you to look at different tissue textures, you can color map this and basically create a virtual histologic map of the tissue. So you can have fibrous tissue, necrotic core, fibrofatty tissue, and dense calcium, and you can easily see all of that with this IVUS system. Artifacts, there are certain artifacts to be aware of. There's NERD, ring down, blood speckle, and obliquity artifacts. I'll go over these very briefly. NERD, or non-uniform rotational distortion, occurs when mechanical systems have some degree of resistance to the rotation. And when the rotational speed becomes non-uniform, you get this type of artifact, as you see on this right upper panel here. Usually it's caused by angulated segments, by curvature in the coronary. If the drive shaft is kinked, it'll happen. If you're inside a small lumen, and sometimes the Touhy-Bosch valve can also contribute to the development of this. Ring down artifact, this is an artifact that you see with stationary IVUS systems. Typically you correct for this as soon as you introduce your catheter into a coronary. It's very easy to take care of. Blood speckle, this is again something that's unique to rotational systems. This is speckling that's created inside the lumen because of slow flow within the lumen. The problem that this creates is that it reduces the contrast. So it's very difficult sometimes to distinguish stuff that's within the lumen from the area around it. So if you're looking for dissections and things like that, it sometimes becomes very difficult to see it when the flow is low. And then there are obliquity artifacts, and this is a fairly simple principle. If you're perpendicular to the wall of the artery, you can get a nice true representation of the size and a good slice here that gives you an accurate estimate of the diameter of the artery. But if your transducers are a little bit angulated with respect to the vessel, you'll cut it in kind of an oblique section and you'll end up measuring larger diameters than the artery actually has. So this is something you have to be aware of. You have to look at the angiogram and see exactly how your catheter transducer is situated with respect to the vessel as you look into making your measurements. This is a nice slide by Dr. Yang showing that if you take a baguette and slice it kind of obliquely, you get longer slices. It's kind of the same principle. OCT has similar principles as IVUS. It's based on light waves rather than sound waves. And basically there's a sample beam and a reference beam. These are emitted and these are used to generate an image. The newer systems are faster because they use frequency domain methods compared with time domain methods of reconstruction. The frequency of near-infrared light is very high, so your resolution with OCT is excellent. You can see beautiful images with excellent detail along the intima and the inner layers of the artery. But because you have a higher frequency, again, because of the principles that we discussed before, the penetration is relatively limited. The other thing is that red cells, if there are red cells within the coronary and you're trying to do OCT, you'll get a lot of back reflection and a lot of swirling artifacts. So when you do OCT, for those of you who are familiar with it, you have to flush the coronary with contrast to remove the red cells and then do your imaging. These are some typical examples of pathology that you can see really well with OCT. This is a calcified plaque, irregular, heterogeneous looking appearance, very characteristic calcified plaque. This is a typical appearance of a fibrous plaque, very thick tissue. And then this is a thin cap fibroatheroma, where you can see the atheromatous plaque and you can see the fibrous plaque right on top of it. So it has very, very good resolution, and you can see beautiful images of these structures with OCT. So just to, again, compare the varying systems that are available, there's a Boston Scientific device, there's a Philips device, and the Abbott device. And this is a rotational IVUS. This is a phased array IVUS. This relies on near-infrared light. There are obviously differences in catheter size and frequency, and correspondingly, there's a difference in penetration and axial resolution, as we've already discussed. So moving on to plaque assessment. You can use imaging to assess the burden of coronary plaque. You can use direct measurements and calculations for this purpose, and this is a typical example of how it's done. You've got a cross-section of a coronary. You can calculate a minimum lumen diameter. You can calculate a maximum lumen diameter. You can get your lumen cross-sectional area by tracing around the lumen. You can get your external elastic membrane area. And then once you obtain these measurements, you can perform these calculations to get your lumen area stenosis, to get your lesion atheroma area, the atheroma burden, and also the remodeling index. It's helpful to familiarize yourself with these formulas because occasionally they'll test these concepts on the boards. The other thing you can look at is the question of hemodynamic significance of plaque, the question of whether you can use imaging to make a decision about intervention. Now, can you use IVUS to do this? And as you think about doing this, you have to distinguish between left main lesions and non-left main lesions. A lot of studies have looked at non-left main IVUS measurements, and they've tried to correlate it with FFR, and they've shown varying thresholds for lumen area, 2.1 to 4.4 square millimeters. And most commonly, the 3 square millimeter criterion is used to assess for significance or to call a lesion significant. The sensitivity of these criteria are very good, but the specificity is very poor. And I fully agree that you really shouldn't be using IVUS to assess the hemodynamic significance of a non-left main lesion. It should be FFR assessment, not IVUS. This trial just came out in the New England Journal at 1682 patients. It compared FFR with IVUS for intermediate stenoses, 40 to 70% stenosis. I think it was published just 2 weeks ago. And here, what they did was they performed PCI if the FFR was less than 0.80. And with IVUS criteria, they were looking at an MLA of 3 square millimeters or 3 to 4 square millimeters with a plaque burden of greater than 70%. And a successful PCI here was defined as an FFR of 0.88 or greater, and a difference between the proximal edge and distal edge FFR of less than 0.05. And the IVUS criteria were a little bit stringent, but basically they were looking at a plaque burden of 55% or less, MSA of 5.5 square millimeters, or equal to or greater than the reference lumen area. And really there was no difference between the primary composite endpoint followed out to 2 years. And what ended up happening, which probably doesn't surprise most of us, is that patients in the IVUS group ended up with a lot more stenting and PCI compared with patients in the FFR group. So again, reinforces that same idea. If you're going to look at lesion significance, if you're trying to make a decision about intervention, you should really be relying on FFR for non-left main lesions. For left main, there's reasonably good data, and there is a good correlation with FFR. You can see in this study here that a lumen area of 5.9 square millimeters was found to be a reasonably good indicator of a significant stenosis. And for board purposes, if you get this question about IVUS assessment of left mains, the magic number is 6 square millimeters. So if it's anything less than 6 square millimeters, it's a significant left main lesion. Anything more than that, you don't have to intervene. The other way of looking at this is to look at the distribution of left main luminal area in normal subjects. And if you go 2 standard deviations below the mean, you get a value of 7.65 square millimeters. I don't recommend using that. I think for the board purposes, again, stick to 6 square millimeters as kind of the threshold for intervention. You can also use imaging to look at culprit lesions. 50% of ACS patients have angiography showing no culprit or multiple potential culprits. If you have multiple potential culprits, you have to determine which one is the appropriate one to intervene on. And here's where OCT is really helpful. You can look at things like plaque erosion. You could look at things like intracoronary thrombus or thrombus on top of a plaque. These things can be very easily seen with OCT and can often help you with those types of clinical decisions in the cath lab. You can also use imaging to determine if a plaque is vulnerable. You can try to predict which lesions will rupture, and this probably has some clinical utility. I think it's more of an academic question these days, but may have some clinical value as well. So to assess that, you have to look at remodeling characteristics, you have to look at virtual histology, and the thickness of the fibrous cap. And when we talk about remodeling, this is what we are referring to. In the presence of a lesion, sometimes the arteries will remodel to a smaller size, and that tends to be a characteristic of stable plaques. Unstable plaques tend to remodel outwards or have positive remodeling. This is interesting data for virtual histology from the PROSPECT trial, and they looked at a number of characteristics, and they tried to determine if the event rates go up with the presence of those characteristics. So if you have a thin cap fibroatheroma, if your minimum lumen area is less than 4 square millimeters, and if your plaque burden is relatively high, all those factors together will give the highest event rate. So it seems to be cumulative. So criteria for a vulnerable plaque, essentially remodeling index of greater than 1.05. If you have a thin cap fiber atheroma, that confers an increased risk. A low minimum lumen area, less than 4 square millimeters, and a plaque burden of greater than 70%. You can also use it to guide intervention, and I think these days that's probably the predominant usage of these modalities in a cath lab. You can use it to determine the appropriate stent diameter. If you're not certain based on the angiogram, you could look at stent apposition and expansion. And you can also use it to determine what caused stent thrombosis, or also in cases of restenosis, it can be a very helpful tool. As you try to size, again, remember this issue of whether your transducer is oriented appropriately with respect to the vessel. If you cut the vessel obliquely in your images, you're going to end up with significant oversizing. So something to be aware of if you use imaging for stent sizing. Other concepts to be familiar with: malapposition. Malapposition refers to the stent not making contact with the vessel wall. And under expansion refers to when the stent is not at nominal diameter. Dr. Yang will get very angry if you use the term under deployment. So please avoid that term. It's an imprecise term. I fully agree with that. And these two things, they're not interchangeable. So this is an example of stent malapposition with OCT. You can see that there are a number of tines of the stent that are hanging out in the lumen of this vessel, clearly well away from the wall here. You can look at stent thrombosis etiologies, and these are typically malapposition under expansion, protrusion, or edge dissection. And these can be all seen really well. This is an example of an edge dissection, fairly large edge dissection. This is a dissection that occurs inside a stent. This is another example. And you can see tissue protrusion through the stent. Sometimes you can see this angiographically as well. Typically in larger vessels, if you do a high pressure dilatation, you can sometimes see tissue protrude through the stent. If you're not sure, you can use imaging to confirm that. It's a factor that does increase your risk of stent thrombosis, so something to pay attention to. This study from the Horizon CMI trial looked at these factors and their contribution to stent thrombosis, and malapposition may not be as bad as we tend to think. It seems like the other factors like low luminal cross-sectional area, tissue protrusion, dissection may be playing a bigger role in the etiology of stent problems. So just to review some of the key points, wavelength and frequency are inversely related. High frequency waves result in greater resolution but have less penetration. Contrast resolution is dependent on the ability to detect changes in the amplitude of the reflected signals. Nerd artifacts occur with rotational systems, and ring down artifacts occur with phase array systems. OCT uses near IR light, which is unable to penetrate red cells, so you have to clear the artery of red cells with a contrast injection. I would again emphasize that you should pay attention to the equations for assessing plaque burden because they're frequently tested on the boards. You should not use intracoronary imaging as a modality of choice to assess the significance of non-left main lesions. You shouldn't use it to make a decision about stenting. 6 millimeters square is the cutoff for left main lesions, and the use of OCT in left main assessment is limited because of the difficulty that you'll have in excluding all blood flow. So typically we use IVUS for that. You can look at plaque erosion and localized traumas on top of the plaque or inside the vessel as characteristic of culprit lesions. And vulnerable plaque characteristics include positive remodeling, thin cap fiber atheroma, minimum lumen area of less than square millimeters, and a plaque burden of greater than 70%. You can use a reference segment to determine the appropriate stent diameter, and again, pay attention to whether your axis is perpendicular or not. You should be familiar with concepts of stent apposition and stent expansion. Predictors of stent thrombosis include under expansion, protrusion, and edge dissection. So this is kind of a nice chart that goes over which modalities to use in what situation. One of the things I wanted to briefly touch upon was some of the clinical stuff with these modalities. Now, if you use a lot of OCT, you're probably familiar with the use of MLD max as the acronym for the things that you need to do to optimize your result using OCT. And what it's talking about is the morphology of the lesion, primarily the extent of the calcification, the thickness of the calcification, the length of the calcification, and you generate a total score based on that. And then there are ways of assessing the diameter of the lesion. You use a distal reference, and there are techniques of doing that. And you also have to make sure there's no medial dissection after the intervention. You look for apposition, and you only treat malapposition if it's greater than 3 millimeters in length or greater than or equal to 0.3 millimeters from the wall of the vessel. Generally, 80% expansion is considered acceptable. Optimal expansion is about 90%. So the guys who use a lot of OCT typically use this algorithm, use these concepts to try to optimize their results with that. There is some clinical data with it. There are a number of studies that have looked at IVUS versus OCT and the outcomes, but there are very few larger size studies, and very few studies have actually looked at clinical outcomes. A lot of studies have looked at surrogate outcomes. So the ILLUMINE 3 trial optimized PCI, this looked at 450 patients randomized to OCT-guided PCI versus operator-directed IVUS-guided or angiography-guided PCI, and really didn't see any difference in the clinical outcomes. But again, this may have been an underpowered study because the numbers were relatively small. There's the ILLUMINE 4 study that is currently underway that will be comparing OCT-guided PCI with angiography-guided PCI, and it will be interesting to see the results of that. The other study that has looked at IVUS versus OCT is the OPINION trial, 829 patients, slightly larger study, again looked at clinical outcomes, and at 12 months didn't really see much of a difference in the clinical outcomes between the two groups. So not very surprising. I think the modalities obviously differ in terms of resolution, what you're looking at, and those types of things, but in terms of their utility to guide interventional procedures, they're fairly similar, and I'm not entirely surprised that there's no difference in outcome between the two. When you talk about the use of IVUS versus angiography-guided PCI, again, there are a number of studies, but there are two that are randomized, larger scale, that look at clinical outcomes and have longer-term follow-up. There's the ULTIMATE trial based on close to 1,500 patients that randomized patients to IVUS-guided PCI versus angiography-guided PCI. And they had, again, somewhat difficult criteria for optimizing PCI with IVUS. Here, you had to have a minimum lumen area of greater than 5 square millimeters. The plaque burden, proximal or distal to the edge of the stent, had to be less than 50% for a 5 millimeter distance. And then you also had to make sure that there was no edge dissection involved in the media with a length of greater than 3 millimeters. And they looked at target vessel failure, which was a composite endpoint based on cardiac death, target vessel MI, clinically driven TVR, which included all these things. And they had multiple secondary endpoints in their study. And what they saw going out to 3 years was that there was indeed a difference between the outcomes of patients who had angiography-guided PCI versus IVUS-guided PCI in the primary outcome. Interestingly, because their optimization criteria for IVUS were rather stringent, they could only accomplish that in 53% of the patients. Most of the times, the problem was accomplishing the less than 50% edge plaque burden criterion in these patients. But when they looked at patients who had suboptimal PCI versus optimal PCI, there was an even more stark difference between the two. These are the 1 year, 2 year, 3 year outcomes. Again, they've looked at multiple endpoints, and the thing that I want to draw your attention to is that even though when they looked at their primary endpoint of target vessel failure, it was significant here, yet some of the other drivers were not that significant. The TVR, clinically driven TVR, just meets significance. But one of the problems here is you get into issues of whether you believe in composite endpoints, how composite endpoints are studied. It also gets into the issues of statistical issues of alpha inflation when you have multiple endpoints that you study. In the original paper that they had published, they had about 14 comparisons at that 1 year mark. And when you have 14 comparisons, if you do kind of a rough calculation, the chances of committing an alpha type error is close to 50%. So you really have to be careful what kind of conclusions you draw from this. The other bigger trial was the IVUS XPL trial. Again, a large number of patients. These were longer lesions, average length of about 35 millimeters. Patients were randomized to IVUS-guided PCI versus angiography-guided PCI. Their primary endpoint was ischemia-driven TLR, and their IVUS criteria for optimization was simpler. You had to have an MLA of greater than the luminal cross-sectional area at the distal reference. And here again, there was a difference between angiographic-guided and IVUS-guided PCI between going out to 5 years. Again, when you look at the breakdown of the primary endpoint, there's no difference in mortality, target lesion-related MI. It's mostly driven by revascularization. Again, multiple comparisons, you get into the issues of composite endpoints and alpha inflation and those types of things. So there's definitely a signal for maybe benefit to using these techniques, but I think it's a little bit hard to make a definitive conclusion.